Please go ahead, Professor Osama.
Good evening. It's a great pleasure to me to be with you in this very interesting webinar. Welcome all professors and my dear colleague and my dear friend, Professor Mohamed El-ashhab, the Dean of Faculty of Medicine, Benha, Faculty of Medicine, Benha University, and welcome for all you professors. Happy to be with you today.
It's a pleasure to meet you, sir. Thank you very much.
Dr. Srinivas was with us in the last Egyptian Orthopedic Association conference, sir.
Okay.
And we are hoping for more and more cooperation between the Egyptian Orthopedic Association and the Indian Orthopedic Association, of course.
It's a very successful cooperation, very interesting subject. So it's a great pleasure to me to join you.
Thank you so much. It's an honor for us, sir.
Thank you for the opportunity.
Dr. Srinivas, OrthoTV is streaming live this webinar.
Yes, sir.
We will start after 7 minutes from now.
Okay.
You will be the first speaker. You will speak about early osteoarthritis of the knee.
Yeah.
And then Professor Osama will speak about non-arthroplastic management of osteoarthritis of the knee.
Okay, sir.
Okay. Thank you so much, sir. I'm preparing. I have arranged the Indian chapter or the Indian session in the next international trauma webinar. It will be from 7 p.m. to 9 p.m. as we have mentioned.
Okay, sir. So it will be 9 to 11.
9:30 to 11:30. That's good.
So the order of speakers, I think there may be a change in the order of the speakers I'll inform you once they confirm the timings to me.
Yes, sir.
When is the last date? I can tell you, sir.
Maybe 1 month from now.
1 month. Okay. Okay.
Yeah, because we have,
also,
we have 2 months.
Okay. And also, may I request the authors for the Egyptian issue?
I sent to them. I sent them to be Harry and send their papers, and 2 of them are ready. They will send it by maybe 1 week, and 3 will send it by maybe 2 to 3 weeks maximum.
That will be great, sir. Thank you.
Thank you so much. Thank you so much, sir. Thank you so much. I have up till now, I have 55 speakers in the international trauma webinar, including our dear Indian colleagues.
Oh, that's excellent.
Yeah, it will be a great
job with this. Lots of webinars, lot of knowledge imparting to the orthopedic community world over. That's a great service.
Thank you so much. It's the we have 3 years working on online teaching, and this is the 4th year, start of the 4th year.
Right.
I hope we can continue.
Yes, sir. Sure.
We have just 5 minutes to start, sir. Our colleagues are starting to be with us.
Okay.
From Egypt and from Yemen.
Okay.
Up till now. Of course, the era of online after the cease of COVID era and the COVID pandemic start to decline a little bit. And of course, the physical and the face-to-face conferences are taking the upper hand. But still, there is a good chance for webinars and for Zoom and for virtual meetings. Still, we have to do some virtual meetings so we can meet with our colleagues from all over the world in the same time.
I agree.
Of course.
Yes, yes.
Egypt and India, I think, were the first countries to start the online teaching.
All right.
Yeah.
Okay.
India had a great successful webinars and participation in the online medical education in the field of orthopedic during the pandemic.
Yeah. OrthoTV has done a great job, actually. They've got a big collection.
Yeah.
Sir, I think there is one session with Dr. Ashok Shyam and Dr. Neeraj Bijlani from OrthoTV.
Yeah.
Dr. Neeraj will be talking. Can we invite Dr. Ashok Shyam as a moderator as well on that session?
Of course, sir. Of course.
Yes, sir. Thank you.
Of course, sir. Can we try, Professor Osama? Can we try sharing your screen before we start our webinar, sir? We have 3 times. Can we try, Dr. Osama?
It's okay.
Yes, sir. Yes, sir. Okay. Can we stop sharing, please, sir?
It's the red button on the top.
Yes. Dr. Srinivas, can we try sharing your screen, please?
Yes, sir.
Yes.
Can you see?
Yeah, I can see it.
Okay, thank you.
We have 2 minutes to start because OrthoTV is very precise. They are remembering me just before 1 minute. It's time for yeah.
They're very well organized, actually.
Yeah. This is not the first time to cooperate with them. About 1 year ago, they were making live streaming of all the presentations in my course.
Okay.
And this is, I hope they can live stream the International Trauma webinar in this very important day.
Okay. Did they
it will be Friday, 25th of August.
Okay. Have you contacted them?
We have time, so I didn't contact them regarding this webinar. But before it, of course, I will send all the information about the time and the beginning. It will last about 10 hours, maybe. It will be a long webinar.
Okay.
Okay. We are ready to start, sir. Can I introduce you, please?
Yes, sir. Thank you.
It's
recording in progress.
It's a great honor for me to announce for this very fruitful day with 2 of our great professors, Professor Srinivas Kambhampati from India, my dear friend and my dear colleague, and the coordinator from the Indian side of the Egyptian-Indian online webinar and course, and from the Egyptian side, my dear professor and my mentor, Professor Osama Hegazy, one of the greatest professors of orthopedic in Egypt and Middle East. Professor Osama is a professor of Orthopaedic Surgery Benha Faculty of Medicine. Professor Srinivas, of course, is the eminent star of knee surgery all over India and all over the world. And he is one of the main professors responsible for online teaching in India and all over the world. Professor Srinivas will start the presentation with a very fruitful presentation from him about early osteoarthritis of the knee. Professor Srinivas, please.
Thank you very much for your kind words, sir. Let me just share my screen. Can you see?
Yes, sir.
So, good evening, everybody. Thank you very much for the invitation. And I would like to thank the Egyptian Orthopedic Association, the Indian Orthopedic Association, and Professor El-ashhab for this opportunity. Thank you for inviting me and giving me the honor of coordinating this wonderful course from the Indian side. Today, I thought I'll talk on early osteoarthritis of the knee. This is a relatively less published topic, which I think we will see more of it in the future and has some interesting concepts. The topic is extensive. So what we can do is discuss here as an overview of the different modalities. And there are some areas that are evolving and evidence of management is unclear and evolving too. And we could share the experiences on this in this platform. I have nothing to disclose in relation to this topic. So the proper definition of early osteoarthritis I will come to later, but osteoarthritis, as we understand now, constitutes affection of the articular cartilage as well as the subchondral bone. We will briefly go through the basic science before going into the management aspects. The normal articular cartilage is avascular, aneural, and does not have a perichondrium and is made up of type 2 collagen. In the stress strain curve, it has a toe region like what we see in other soft tissues. Biomechanically, it exhibits a biphasic behavior for compression. So it behaves differently when loaded from different directions. It is anisotropic and inhomogeneous for tensile forces. And it is lubricated by the synovial fluid through which it also receives its nutrients. Histologically, it has a superficial layer, intermediate layer, and deep layer. Below that is the calcified layer and the subchondral bone. On the left, you see the cells, and on the right, you see the collagen bundles. So the bundles and cells are parallel to the surface superficially and perpendicular to the surface in the deepest layer where they bear the loads. Early osteoarthritis is histologically graded from 1 to 3 by the ORC, which is an international society for the study of osteoarthritis. This takes into account the depth of degradation into the articular cartilage. In the early stages of osteoarthritis, the articular cartilage surface becomes discontinuous with fibrillation and vertical fissures extending into the mid-zone of the cartilage. There is also a progressive increase in subchondral plate and subarticular spongiosa thickness in the subchondral bone. ORC grades 1 to 3 are reflective of early osteoarthritis, with stages 1 having less than 10% joint involvement and stage 4 with more than 50% joint involvement. Early osteoarthritis affects not only the articular cartilage, but also other structures of the joint. So there's a need for targeted therapies for this stage of the disease. So if we look at the grading here, grade 1 is characterized by mild distortion or fibrillation of the surface. Grade 2, smaller parts of the cartilage surface are lost and cracks may form that extend deeper into the superficial zone. The depletion of cartilage-specific matrix staining commences, and chondrocytes begin to form clusters as a result of their cell division. And grade 3 shows vertical fissures that penetrate into the middle zone of the articular cartilage. And grade 4 shows erosion of articular cartilage with delamination and excavation. Most people will acquire degenerative cartilage and osteoarthritis as they age. Due to several factors, healthy articular cartilage loses some of its integrity after around 40 years of age. And mechanical factors like obesity, compartmental overload, loss of joint congruity, and joint instability worsen age-associated biochemical changes in the extracellular matrix. So that decreases tensile strength, elasticity, and covalent cross-linking of the collagen fibrils due to age accumulation. Age stands for advanced glycation end products. So osteoarthritis is caused by a failure to balance this catabolic and anabolic processes in the cartilage and subchondral bone unit. OA chondrocytes produce more and coordinate cytokines. They activate inflammatory pathways and promote catabolism. Early osteoarthritis mechanical stress causes chondrocyte necrosis and death. And this alters biomechanical control of articular cartilage metabolism. Due to excessive loading and inability to absorb these stresses, the cartilage fissures and microcracks in the calcified layer and subchondral bone result. A lot of work, there's a good review by Dr. Madri on this topic, especially early osteoarthritis on the subchondral unit, subchondral bone and articular cartilage. The subchondral bone is defined as a zone that separates the articular cartilage from the marrow cavity and is composed of the subchondral bone plate and the subarticular spongiosa. The subchondral bone plate lies immediately below the calcified zone of the articular cartilage, while the subarticular spongiosa is basically trabecular bone. And subchondral bone plate is separated from the calcified zone of the articular cartilage by the cement line. And restoration of subchondral bone is crucial in order to allow for new articular cartilage formation in large osteochondral defects and may prevent secondary changes in the surrounding bone and articular cartilage, prolonging the durability of the new repair tissue. And defects in articular cartilage are classified as partial thickness when only part of the cartilage is involved, full thickness when up to the subchondral bone is involved, and osteochondral when even the subchondral bone is involved. The subchondral bone plate plays a very important role in the onset and pathogenesis of osteoarthritis because it is bound to the articular cartilage by the cement line. And changes in the subchondral bone plate, together with changes in the mineral content and thickness of the calcified zone and the advancement of tide mark as a result of overloading of the articular cartilage and the subchondral bone, contribute to the development of osteoarthritis. Looking at the biology, chemokines are mediators of inflammation and immunity and are highly expressed in chondrocytes affected by osteoarthritis. And these are CC and CXC chemokines, and they are expressed, they have receptors for both chemokine subfamilies. Engaging chemokine receptors can induce the release of matrix degrading enzymes and lead to chondrocyte cell death. So chemokines and their receptors play an important role in osteoarthritis. The osteochondral unit is a combination of articular cartilage with the underlying subchondral bone. So these two are important in developing early osteoarthritis. Now, coming on to the clinical definition of early osteoarthritis, this includes at least 2 episodes of pain for more than 10 days in the last year and a KL grade of 0, 1, 2, that is formation of osteophytes only on X-rays, and structural criteria including arthroscopic or MRI findings of cartilage lesions. In the Japanese general population, data showed that the prevalence of OA was 9.5% in males and 15% in females. The prevalence increased with age, and the highest prevalence was noted in 50 to 59 age group. Risk factors for OA include age, sex, obesity, and history of knee injury. They typically present with intermittent swelling, pain with weight bearing, and symptoms of other causes of OA like meniscus or ACL insufficiency. Examination findings include point tenderness, meniscal signs, ACL signs, patellar grinding if patella is involved. Imaging includes weight-bearing AP, lateral view, Rosenberg view, which is basically a flexed knee AP view, shooting parallel to the tibial surface, and long leg weight-bearing alignment views. MRI is the gold standard and is 90 to 95% accurate and includes scoring using different systems like worms, blocks, and mokes. The state of articular cartilage, meniscus, bone marrow lesions, subchondral cysts may be looked at, and subchondral fractures and osteonecrosis can also be picked up. If any changes are seen on X-rays and MRI without symptoms, these may only be considered risk factors for OA, but not regarded as early osteoarthritis. So you can see this is a busy chart. This includes the management of early osteoarthritis. There are mainly 2 arms, non-operative and an operative arm. Under non-operative, non-pharmacological, pharmacological, and injective therapies are present. We'll go through the operative part later. Coming to the pharmacological management, there are different pharmacological preparations available. Paracetamol is the most commonly used. It acts on COX-3 downregulation and nitric oxide inhibition. It is usually the first-line agent for managing OA. It is low cost, safe, and most commonly used. Caution should be exercised in liver disease, warfarin takers, chronic alcoholics, and long-term use. NSAIDs are different groups, propionic acid derivatives, acetic acid derivatives, enolic acid derivatives, non-selective phenamates and non-selective, they act by non-selective COX-1 and COX-2 inhibitors. And caution should be exercised in peptic ulcer disease, asthma, renal problems, and chronic renal failure. COX-2 inhibitors are selective COX-2 inhibitors. Examples are etoricoxib and celecoxib. Earlier drugs used to cause cardiac adverse effects. The later ones have lesser effects on the heart. Topical agents are rubifacients. They act by increasing local blood flow. Opioids are powerful analgesics. For acute exacerbation of osteoarthritis, they may be used. Commonly used one is a weak opioid, tramadol, and the side effects include nausea, vomiting, dizziness, and constipation. Intra-articular agents and nerve blocks. We'll talk about intra-articular agents with injectables. Nerve blocks and ablation, these are usually done for unfit patients and with advanced disease. Symptomatic slow-acting agents include diacerin, this is banned in European countries for its GI side effects, glucosamine and chondroitin sulfate. Given individually, they don't have an effect, but in combination, there is limited evidence that they may have an effect in combination. Collagen, there is a potential agent as supplement for therapy of OA. So the overall analysis on these, including all trials, showed that supplements provided moderate to clinical meaningful treatment effects on pain and function in patients with hand, hip, and knee osteoarthritis at short term, although the quality of evidence was very low. This was from a meta-analysis. Others include supplements and herbals. There is limited evidence for use of these. Pain management could also be done using gabapentins, pregabalin, and vitamin D and bisphosphonates have also been tried. Duloxetine is a serotonin norepinephrine reuptake inhibitor approved by the FDA to relieve pain and improve function in patients with knee OA. Among non-pharmacological modes, we have exercises. Physiological loads are healthy for articular cartilage, but excessive and abuse of loading is unhealthy for articular cartilage. There is limited evidence for early osteoarthritis, especially the type of exercise, frequency, duration, and the intensity. The choice depends on patient-specific conditions. Regarding braces, offloading braces may have a role by reducing the loading, but they may be cumbersome. Some patients don't like them. Physical therapy, exercises we have talked about. Other therapies could include acupuncture. Injectable therapies, we have corticosteroids. The commonly used one is triamcinolone. It is recommended by the recent clinical practice guidelines in most countries. It has an anti-inflammatory effect, which is local, more than systemic, and reduces synovitis-associated symptoms, may be given for advanced disease. It has short-term benefits. There are no long-term benefits. Caution should be exercised in diabetes especially, and infection. There's no use with the repeated use, so repeated injections are not advisable. Viscosupplementation, although this was recommended in the earlier clinical practice guidelines, recent ones, especially the American AAOS clinical practice guideline, does not recommend this for osteoarthritis. Caution is advised against anaphylaxis, chemical synovitis, and infection. PRP can be categorized as leukocyte-rich plasma or leukocyte-poor PRP or platelet-poor PRP, depending on the preparation technique. The ingredients of PRP categories vary depending on which system is used to prepare autologous blood. So care must be taken when choosing the method. Leukocyte-rich PRP has been found to cause initial pain and swelling, possibly due to release of pro-inflammatory mediators. So recent studies evaluating both the forms, leukocyte-rich and poor, have found that the results of the two groups are comparable, but local adverse effects were more common with the leukocyte-rich PRP. There is no one gold standard. So injections of PRP can be done once or in cycles of 3 or more injections. The highest beneficial effect is seen at 6 months after cycle of injections. However, it may last up to 2 years. Authors of a meta-analysis of randomized controlled trials using PRP for OA concluded that statistically significant beneficial effect over placebo was observed at 6 to 12 months. And it was shown that PRP is more effective both in short and long-term pain and functional recovery when compared to HA. For autologous conditioned serum, patient's blood is incubated in inert substances like glass beads, which stimulate release of anti-inflammatory cytokines and growth factors. And the serum is then separated and used. Clinical applications are primarily in orthopedics for musculoskeletal conditions, while PRP has broader applications in other multiple medical specialties. But the outcomes are similar to PRP, but better than HA. BMAC is bone marrow aspirate concentrate. The bone marrow aspirate itself has only about 0.0001 to 0.01% of stem cells, mesenchymal stem cells. So BMAC contains growth factors. A concentrate of this contains PDGF, TGF-beta, and BMP2 and 7. BMAC plus hyaluronic acid scaffolds are used in articular cartilage defects, and BMAC versus PRP in a study showed no difference between the two. Stem cells appear to have a promising future. The source of stem cells can be from embryonic or adult tissues, allogenic or autogenic. Embryonic sources include umbilical cord, amnion, placenta, and Wharton's jelly, while in the adult, bone marrow and adipose tissue are good sources. After injection, they showed metachromasia and hyaline cartilage-like tissue, and almost all types showed better outcomes compared to placebo at 2 years. Adipose tissue has 25,000 times more stem cells compared to the marrow. The main areas of harvesting are abdominal and supragluteal areas. So far, studies have shown no superiority of these over PRP, but this may change in the future. Major causes of osteoarthritis include overloading, malalignment, meniscus defunctioning, and post-traumatic sequelae. We'll just go through these shortly. Overloading is seen among elite athletes and obesity. So among elite athletes, ACL and meniscal injuries are very common. The incidence of osteoarthritis and total knee replacement is also higher when compared to the same age in normal population. Meniscal injury and articular injury, cartilage injury increase osteoarthritis incidence significantly. And this also, the articular cartilage injuries are also common in other sport injuries. Cartilage injuries are common with meniscal injuries, and the causes for osteoarthritis include higher tibial slope, genu recurvatum, genu varum, morbid obesity, high-intensity physical activity, younger age at injury, delay in treatment, and associated ligament injuries. Posterior horn medial meniscus injury has been associated with injury and recurrent injury to the ACL as well, because it is a secondary stabilizer of ACL. Regarding obesity, radiographic osteoarthritis was found in those with higher BMI, and a study with over 1 million subjects found that compared to normal weight, overweight or obesity increased risk of osteoarthritis in hip, knee, and the hand. Moving on to malalignment, this can happen coronal, sagittal, and rotational. Corrective osteotomy of genu varum is high tibial osteotomy with medial open wedge or a lateral closed wedge. For genu valgum, the femur is usually the culprit, so distal femoral osteotomy is preferred. For angular or rotational deformities, Elizaro and other limb reconstruction techniques may be used. To correct the tibial slope, if the slope is more than 12 degrees, slope decreasing osteotomy is done. This could be combined with a HTO or as an anterior closing wedge osteotomy. If the slope is less, slope increasing osteotomy is done using anterior open wedge osteotomy, and this can also be done using a high tibial osteotomy. For rotational malalignment, an appropriate derotation osteotomy may be done. Moving to the meniscal defunctioning, root tears have been described as a silent epidemic. Why? Because they have non-specific pain. The mechanism is low energy. Often no significant trauma is reported, and maybe the pain may be disregarded as an acute exacerbation of osteoarthritis. Radiographs show no changes or minimal early osteoarthritic changes. MRI is sometimes difficult to diagnose these lesions and may be easily missed, and they account for about 10 to 21% of all meniscal tears, affecting nearly 100,000 patients annually in the USA. Posterior roots are more common than anterior roots, and non-traumatic is more seen in the degenerative age group. And they lead to rapid osteoarthritic changes. They are associated with spontaneous osteonecrosis of the knee. Conservative management of root tears leads to 87% failure rate with 31% conversion rate to total knee replacement. And among those who had total knee replacement, 78% of the patients had root tears in another study. So most medial meniscus posterior root tears occur in 4th to 5th decades of life. Meniscus protects and distributes the hoop stresses. The posterior root is a secondary stabilizer of ACL, and its tear increases the effects of posterior tibial slope at 30 degrees of flexion. And root tear totally defunctions the meniscus and leads to OA changes within 6 months to 2 years. And MRI is the gold standard for diagnosis, and the signs of root tear in MRI include fluid around meniscal roots, more than 3 millimeters meniscal extrusion on coronal images, the ghost sign, and radial tear seen in coronal and axial images called the truncation sign. SONC and or SIF lesions are due to root tears. Poor results have been reported with non-operative management leading to osteoarthritis in 1 to 2 years. Meniscectomy or partial meniscectomy in these cases is worse than leaving meniscus alone, and the gold standard is transtibial pull-out repair of the meniscus. ACL reconstruction with lateral meniscus posterior root tear leads to healing of meniscus in more than 90% cases. And medial meniscus posterior root tear repair improves outcomes and slows down osteoarthritis. Root repair slows OA compared to conservative and partial meniscectomy. And age is not a contraindication for repair, and outcomes improve after more than 12 months. Anatomic root repair is better than non-anatomic, and root repair slows down osteoarthritis and significantly reduces total knee replacement rates at 5 years. Moving to radial tears. The repair techniques include cross suture, hashtag suture, cross-tag suture, or a Union Jack repair. Other techniques also include anchor, tunnel, or all-inside devices. Lateral meniscus oblique radial tears, these are caused by pivot shift mechanism, and they occur in 23% of lateral meniscus tears, and they represent 12% of all meniscal tears. Repair outcomes for the radial tears. After repair, 62% show complete healing, 30% partial healing, and 8% fail. Moving on to meniscal extrusion. We have written a narrative review about it. The causes include meniscal causes, non-meniscal causes, and post-operative causes. Management includes centralization of the meniscus, basically improve the visualization. You may need to do an MCL fractional lengthening, reverse notchplasty or medial tibial spine resection, stabilize the posterior and anterior roots, and reduce and stabilize the meniscal body. The sutures on the meniscus have already been placed here, and they are pulled into the tibial tunnel, which is placed on the tibial plateau. And when the sutures are pulled, you can see the meniscus reducing from the extruded position. Meniscal defect and deficiency also defunction. They are treated using meniscal scaffolds. The scaffolds are of two types, natural and synthetic. Natural are tissue, perichondrial tissue, hyaluronan, or meniscal transplants. Synthetic ones are polyurethane, PGA, PLGA, polycaprolactone, or hydrogels. Among synthetic scaffolds, collagen meniscal implant and ActiveFit look similar, and new surface is a lower femur conforming implant. Going on to post-trauma sequelae. Bone marrow lesions, we'll restrict to the osteoarthritis-related bone marrow lesions. They are defined by being adjacent to articular cartilage in a joint with structural osteoarthritis and without any visible fracture line. Adjacent cartilage lesions are often of high grade. BML shows high metabolic activity, inflammation, angiogenesis, and bone turnover. There's increased trabecular thickness, disruption of osteochondral junction, and subchondral microfracture. And interventions that redistribute stressors by orthosis or tibial wedge osteotomy may reduce the BML size. Obesity or dietary lipid intake and high physical activity might contribute to genesis of the bone marrow lesions. And people with knee OA who have these lesions are 2.5 times more likely to have knee pain than those without these lesions. And there's strong association between bone marrow lesions and structural progression within the same compartment. And the attempts, the strategies to reduce the bone marrow lesions have targeted mainly the subchondral bone turnover, like using bisphosphonates or strontium, etc., or reducing biomechanical stresses by bracing or high tibial osteotomy, remove or replace the bone marrow lesion using subchondroplasty or arthroplasty, or restore normal cellular function using BMAC or PRP. Moving to chondral osteochondral injuries, 40 to 70% of cartilage injuries are associated with ACL. Up to 50% of meniscal injuries are associated with cartilage injuries. So this is an overview of the articular cartilage injuries. Less than 4 centimeters square, microfracture has been preferred. More than 4 centimeters, AC, MACI, osteochondral autograft transplantation, and particulate juvenile allograft transplantation have been done. It is important to see if they are whether they are contained defect or non-contained. Contained, we could use microfracture AC or MACI. Uncontained, OAT can be utilized. The health of surrounding cartilage is also important. If it is healthy, the results are good. If it is not healthy, there is a risk of failure of articular cartilage restoration procedures. So marrow stimulation techniques lead to formation of fibrocartilage repair, and so the replacement is inferior than the native hyaline cartilage. So the limitations of microfracture are actually decreasing. because the long-term results of microfracture are not as good as AC or MACI. So these can be used for only smaller lesions. For bigger lesions, ACI is used and has been shown to have good results for multiple lesions and bipolar defects. MACI is actually expanding indications and better results than microfracture in the long term. This is an overview of the cartilage injuries. If we come to the fractures, anatomically, they require anatomic reduction and stable fixation for tibial plateau fractures. Step-off should be less than 3 to 5 millimeter to lead to better outcomes. And malunions also can lead to early OA. So to summarize, the priorities of managing, the first priority would be to restore the alignment. So treat malalignment using corrective osteotomies for the tibiofemoral compartment, high tibial osteotomy, slope correction osteotomies, distal femoral osteotomies for the patellar compartment, tibial tubercle osteotomy, soft tissue realignment, MPFL reconstruction, and trochleoplasty. And if the deformity is more proximal or distal in the diaphysis, limb reconstruction techniques. Priority 2 would be to stabilize the knee, to fix the fractures or reconstruct the ligaments. The next priority is to restore the meniscus using root repairs, radial tear repairs, centralization procedures, or meniscal transplants. And then the articular cartilage procedures, OATS, ACI, MACI, and microfracture techniques. Bone marrow procedures include subchondroplasty. Their recent developments, further studies are required to establish exactly their role in this treatment algorithm. And another option is that has been reported in the literature is proximal fibular osteotomy. We've done a review on this. The evidence is limited. It is used for medial compartment osteoarthritis only. And they have been reported for KL grade 1, 2, and 3. So to summarize, it is important to identify early osteoarthritis for effective management and slowing down damage. Identify the cause or causes and risks of early osteoarthritis. Look for silent meniscal issues. Non-operative and operative options are evolving. Non-operative and injection strategies are the first line in majority of the cases unless associated with obvious surgically correctable causes. Aim of the treatment is to slow down or delay progress to advanced osteoarthritis. Effective management slows down progress of osteoarthritis. Identify priorities in surgical management, and combination of strategies may be useful in some cases. Thank you very much.
Thank you so much, Dr. Srinivas, for this very, very presentable and very interesting talk about osteoarthritis, early osteoarthritis of the knee, and their management, whether it is pharmacological, conservative, or surgical. Thank you so much, sir, for your presentation. We are waiting for any questions from our dear colleagues. May I start with my question? Sir, do you prefer to inject hyaluronic acid or PRP or growth factors?
So what is the third one, sir?
Growth factors.
I prefer in my practice PRP over hyaluronic acid, sir.
Yeah.
I have had a few patients with chemical synovitis, which is not seen with PRP injection. So, and the recent results show PRP better than hyaluronic acid, and even national clinical practice guidelines say PRP is better than hyaluronic acid injections.
You make the activation before, of course, before you inject it.
No, we don't.
You don't make an activation.
I think Professor Dhillon in his speech had also mentioned about this. It does not require activation.
Yeah. And what about corticosteroids? Most of us do not prefer corticosteroid injection in osteoarthritis of the knee. What's your opinion, sir?
I prefer to give them in advanced stages, especially those patients with synovitis. They have a role, But repeated injections, I do not give. I give a single injection of corticosteroid in advanced osteoarthritis. I don't think they have a role in early osteoarthritis because
Yes,
they can affect the articular cartilage.
Yes, of course. Professor Osama, you have any questions, sir, to Dr. Srinivas?
No, but thank you for this and very interesting presentation, very interesting and very comprehensive.
Thank you, sir.
We have no questions up till now, Dr. Srinivas, so we will move to our next speaker. Our next speaker will be Professor Osama Hegazy. Professor Mohamed Osama Hegazy will speak about non-arthroplastic management of osteoarthritis of the knee. Welcome, sir.
Good evening. Again, I would like to thank Professor Srinivas for this interesting presentation. And again, I would like to thank my dear friend and my dear colleague, Professor Mohamed El-ashhab, for inviting me to speak today. Early treatment of knee osteoarthritis. The update guidelines offers evidence-based recommendations to determine best treatment options of knee osteoarthritis. Treatment of knee osteoarthritis are three. Non-medical treatment, medical treatment, and surgical treatment. American Academy of Orthopedic update clinical guidelines. Evidence-based recommendation help determine the best treatment approach. The guidelines include only treatments which are less invasive than knee replacement surgery to provide pain relief and improve patient's function. Treatment of knee osteoarthritis start with first-line treatment, education, exercises, and weight control. First and second-line treatment, as mentioned, Professor said. The last-line treatment is surgery for non-arthroplasty or arthroplasty options. Surgery for treatment of knee osteoarthritis. A surgical option should be considered only to manage osteoarthritis after exhausting conservative options. The treatment should be modified based on patient age, demands, and symptoms. A realistic expectation should be offered to the patient based on available evidence to have a satisfied patients. Surgery for knee osteoarthritis are two main groups. Joint preserving surgery by doing osteotomy or arthroscopic debridement or cartilage repair. Joint replacing by unicompartmental or total knee replacement. The goals of treatment of osteoarthritis are slow down the progression of the early form, pain relief, preserve as much as possible joint mobility and function. Joint preserving surgery for new osteoarthritis, again, osteotomy, arthroscopic debridement, or cartilage repair. Determining which of these procedures is most appropriate depends on symptoms and the stage of the osteoarthritis, age, and demands of the patient. But the optimum treatment option may change over time for the patient. There is no standard rules. We start by knee osteotomy. Knee osteotomy is recommended for physiologically young and active patients meeting the prerequisite criteria. What are the prerequisite criteria for knee osteotomy? Active young patient, body mass index less than 35, flexion contraction less than 5 degrees, knee range of motion up to 90 degrees, one compartment affected, content agents. Those are the standard prerequisites or essential prerequisites for doing knee osteotomy for early osteoarthritis. The goal of knee osteotomy is to transfer weight from the arthritic part of the knee to a healthier area, correct knee alignment, realign the limb. Realign the limb will slow the spread of osteoarthritis throughout the rest of the joint, prolong lifespan of the knee joint. The advantage of knee osteotomy, preserving the knee joint anatomy, may delay the need for joint replacement for several years. It's very essential factor. There is no restrictions on physical activities after osteotomy has healed. The knee osteotomy, unloading osteotomy are high tibial osteotomy, proximal fibular osteotomy, or distal femoral osteotomy. Who is good candidate for knee osteotomy? A good candidate for knee osteotomy is a patient who has persistent pain in one compartment of the knee and limb malalignment that has failed to conservative treatment. The alignment principle, we should know the alignment principles will very a good guide for decision making for which osteotomy is needed for each patient. The mechanical axis passes from the center of the hip through the knee to the center of the tibial joint. The orientation of the normal anatomic axis of the knee is 5 to 7 degree valgus. The articular surface of the tibia average 3 degree varus, and that of the femur 2 to 3 of valgus relative to the mechanical axis. With varus alignment, the deviation of 1 degree varus from the neutral alignment increases the medial load by 5%. Varus alignment of more than 20 degrees considerably increases the probability of developing osteoarthritis.
I'm sorry, Professor Osama, I think the slides are not working.
It's not working?
Yeah. Now we are in the slide. Who's a good candidate for knee osteotomy?
Yeah. It appears now?
No, sir. The same slide, a patient who has persistent knee in one compartment of the knee and limb malalignment that has failed conservative treatment. It's the same slide.
The next slide is not appear now?
No. You can stop sharing, sir, and try sharing screen another time.
Okay. Okay.
Yes, sir. Yes, it's obvious now, sir.
Okay. The alignment principle are the mechanical axis passes from the center of the hip through the knee to the center of the tibial joint. The orientation of normal anatomic axis of the knee is 5 to 7 degrees valgus. The articular surface of the tibia average 3 degrees varus, and that of the femur 2 to 3 of valgus relative to the mechanical axis. So the varus alignment deviation of 1 degree varus from the neutral alignment increases the medial load by 5%. Varus alignment of more than 20 degrees considerably increase the probability of developing osteoarthritis. So, high tibial osteotomy indicated in patients with unicompartmental knee osteoarthritis to improve pain and function. The aim of osteotomy is to overcorrect the mechanical alignment to 3 degrees of valgus, 3 to 5 degrees of valgus. It's contraindicated in advanced osteoarthritis, in the inflammatory arthritis, and the large areas of bone exposure. This is tibial osteotomy, high tibial osteotomy. It's the preferable osteotomy in osteoarthritis is the oblique osteotomy because it has many advantages. It's less invasive. It could be done, the osteotomy line could be ended above the tibiofibular joint, so there is no need to do fibular osteotomy. It's easy to do and simply to fix by different fixations. This is high fibular osteotomy. It starts just at the level of the upper tibial tuberosity, and passes like that, and then 1 centimeter from the lateral cortex. The osteotomy is open like that. There is no need to do it just above the tibiofibular joint. There is no need to do a fibular osteotomy. It's open wedge osteotomy. It could be fixed by plates with or without bone graft. So it will improve the malalignment of varus deformity of the knee. This is example, medial compartment osteoarthritis. This is a line of osteotomy. This is another example. It's the medial compartment osteoarthritis, healthy lateral compartment. And this is osteotomy. They preserve the far cortex. This improve the varus malalignment. There is no need to do fibular osteotomy and simply to fix with plate and screw. This is another case, and this is the same. Oblique osteotomy, easy to do, small incision, no need for fibular osteotomy, stable osteotomy. Another fibular osteotomy is a fibular or proximal fibular osteotomy. The fibula acts as a strap to load 1/6 body weight and prevent uniform setting to proximal tibia. This contributes to increased stresses of the medial tibial plateau and development of varus knee. The principal osteotomy, the proximal fibular osteotomy, redistribute the loading of tibial plateau and relief pain, so it will overcome the loads, excessive load of the medial femoral or medial tibial condyle. But only few short-term studies are available. There is no enough studies. This is illustrate what this is the normal distribution of load. In osteoarthritis, is excessive load on the medial joint, medial condyle. After fibular osteotomy, the load is redistributed, so the excess load on the medial tibial condyle is reduced like that. This is the principle of fibular osteotomy. It decreases the load, excess load in the medial tibial condyle, and redistributes the load like that, so there is improvement in the compression on the medial femoral condyle, medial tibial condyle. This is example fibular osteotomy. It's a new surgery for pain relief and improvement of joint function in patients with knee osteoarthritis, published in the Journal of International Medical Research, 2017. This is example of the results of fibular osteotomy. This is excessive medial compartment osteoarthritis, excessive medial compartment osteoarthritis, and this is the result after doing a fibular osteotomy. The joint space is widened, the compressive load is decreased. This is another example of fibular osteotomy. This is excess load on the medial joint line, and this is the results after fibular osteotomy. Distal femoral osteotomy is another type of osteotomy. It's indicated for young active patients only, also with only osteoarthritis in the lateral compartment. Osteoarthritis in the lateral compartment, they may be benefit from distal femoral osteotomy. When a valgus deformity exceeds 12 degrees or joint surface deviates from the horizontal to more than 10 degrees, the deformity should be corrected on the femur. Realigning the leg helps to take the pressure off the diseased lateral compartment of the knee and relieve pain. Realigning the limb slows up the spread of osteoarthritis throughout the rest of the knee joint. And this is example of distal femoral osteotomy. It's also done in an oblique osteotomy. Don't reach the far cortex. As the same as the tibial osteotomy, this is the proximal tibial osteotomy, will realign the malalignment and fixed by plates screws, and this will decrease the load on the lateral compartment of the knee and improve the function later on. This is example of this is lateral, also associated lateral compartment. This is osteotomy, and this is the results. This is another example. Becomes the second line of treatment of joint preserving surgery is the joint debridement. Joint debridement can be used only for patients with mild to moderate osteoarthritis presented with clicking or locking and degenerative menisci for improvement of mechanical symptoms only. It's not for treatment of osteoarthritis, but it's for treatment of mechanical symptoms and clicking, locking, and mechanical symptoms associated with knee osteoarthritis. And this is not for alter the disease progression. It not alter the disease progression. Osteotomies may delay the disease progression. Osteotomies may delay the disease progression. Arthroscopic debridement will not alter the disease progression, but improve the mechanical symptoms which is associated with osteoarthritis. And this is according to the American Academy Association guidelines. Is very strength of recommendation is moderate strength of recommendation. Thus, for arthroscopic debridement is not a routine lavage or is not a routine treatment of osteoarthritis, but it just to treat the mechanical symptoms which is associated with osteoarthritis, provided it's mild to moderate osteoarthritis. Arthroscopic partial mastectomy also not used to treat osteoarthritis, but can be used for treatment of degenerative meniscal tears in patients with mild to moderate osteoarthritis who have failed physical therapy or other non-surgical treatment. And also the strength of recommendation according to the American Academy guidelines is moderate strength. The third line of treatment of joint preserving surgery in osteoarthritis are cartilage repair and cartilage restoration. And damage to the articular cartilage can result in a variety of symptoms and can initiate the onset of osteoarthritis. Patients who have cartilage defects can benefit from surgical procedures of cartilage repair to delay the need for total knee replacement surgery. Cartilage repair. What is cartilage repair? Surgery consists of regenerating or replacing cartilage either with tissue from the patient's own body or by generating cartilage repair tissue in a lab. Who is a candidate for cartilage repair? A patient with isolated articular cartilage defect. The patient should have a relatively healthy knee with no generalized cartilage loss. The treated knee should be well aligned and stable with low ligament deficiency. Cartilage repair can be performed on people of all ages, but typically patients are under the age of 50 years of age. Many lesions in one joint are less likely to benefit from the surgery. This is the criteria for selection of cases to be to be treated by cartilage repair. Successful cartilage repair surgery reduce pain and restore function, delay or prevent the onset of osteoarthritis. There are numerous cartilage repair treatment options available, but the suitability of each depends on each patient and clinical problem. Last advances in cartilage repair and regeneration, but cartilage repair is most commonly used to treat isolated cartilage defect. Cartilage repair surgery is not performed to treat arthritis, but more appropriate for people trying to slow or prevent severe arthritis rather than to alleviate it. So the joint preserving surgery is to delay the progression of osteoarthritis and improve function of the patient. Cartilage repair and cartilage restoration are three types. Bone marrow stimulation. osteochondral autograft transplantation, autologous chondrocyte implantation. Bone marrow stimulation, which stimulates cartilage growth by making precise microfractures in the surrounding bone. Osteochondral autograft transplantation, transplanting cartilage from one side to another. Autologous chondrocyte implantation requires two surgeries. The first, cartilage cells are harvested and then grow in laboratory for several weeks. During the second surgery, the cartilage cells are re-implanted. We start by bone marrow stimulation. Bone marrow stimulation is a procedure to release mesenchymal stem cells from the bone to promote healing of the articular cartilage defect. Bone marrow stimulation could be done by one of microfracture, subchondral drilling, or abrasion arthroplasty. Microfracture. The goal of microfracture is to stimulate the growth of new articular cartilage by creating a new blood supply. An owl is used to make multiple holes in the exposed subchondral bone. The new blood comes, a new blood supply is able to reach the joint surface, bringing it to cells that will form the fibrocartilage. So the microfracture is used for small lesions to allow, done by owl, to make multiple holes in subchondral bone. So the blood comes from the subchondral bone, bringing the stem cells that will form fibrocartilage. Drilling, similar to the microfracture, drilling simulates production of healthy cartilage. Multiple holes are made in the subchondral bone with surgical drill or wire. The subchondral bone is penetrated to create healing response. The same like microfracture, drilling yields fibrocartilage. But drilling, deep drilling of the cartilage defect results in improved biological features compared with microfracture, including less damage to the subchondral bone and the greater access to marrow stroke. Abrasion arthroplasty is a high-speed burr are used to remove the damaged cartilage and reaches the subchondral bone, promote bleeding and formation of fibrocartilage, which covers the damaged area. Fibrocartilage is not normal articular cartilage, but is beneficial in decreasing symptoms. Abrasion arthroplasty is effective in treating a localized area of damaged cartilage, which are not too large. Osteochondral autograft transplantation. Cartilage is transplanted from one part of the joint to another. Cylinder-shaped blood graft is healthy.
دكتور أسامة؟
محمد انا مش عارف ضغط شويه. اوكي يا محمد. كارتلج سوري انا حسيت الدنيا لفت بيها شويه.
لا براحة حضرتك فندم.
To start again, osteochondral autograft transplantation. Cartilage is transferred from one part of the joint to another. A cylinder-shaped plug or graft of healthy cartilage tissue and subchondral bone is taken from non-waiting part of the bone. The graft is then matched to the surface area of the defect and pushed into place. This leaves a smooth cartilage surface in the joint. A single plug of cartilage may be transferred or multiple plugs, which is called mosaicoplasty. This procedure is considered only for younger patients who have small areas of cartilage damage. This is mosaicoplasty. Autologous chondrocyte implantation, two steps procedure in which cartilage cells are harvested and grown in a laboratory for several weeks. The second surgery of the cartilage are implanted in the cartilage defect. How effective is preserving surgery for osteoarthritis is a question to be asked. Joint preservation surgery aims to preserve the knee as long as possible to prevent or delay the onset of osteoarthritis, especially in young patients. Joint preserving surgery avoid or delay the need for knee replacement surgery. When joint preservation surgery offered, joint preservation surgery is offered after thorough assessment, including patient symptoms, patient-related factors such as age, level of physical activity, and patient comorbidities, clinical examination, X-ray of the knee and long leg alignment views for varus alignment and valgus alignment, MRI finding in cases with mechanical problems, arthroscopic finding if needed. Choice of treatment based on a knee osteotomy for patients with varus or valgus malalignment, arthroscopic debridement for patients with symptomatic meniscal tear and loose bodies with locking symptoms. Cartilage repair is indicated for isolated cartilage defect in a relatively healthy knee. Will all joint preservation patients need replacement surgery? This is the question. The results of joint preservation surgery are generally good, with 85% of patients not requiring joint replacement surgery after 10 years. Thank you.
Thank you so much, Professor Osama, for this very interesting presentation, sir. Thank you so much, sir.
Thank you, Mohamed.
We are waiting for questions from our colleagues. My first question to Dr. Srinivas and Professor Osama. Many of our colleagues are asking in medial compartmental osteoarthritis about what's the difference between, or which is more better, medial high tibial osteotomy or unicompartmental unicompartmental replacement. And I think, in my opinion, there is no evidence for such a question, because as we all know that the unicompartmental osteoarthritis, I have a limitation of the varus present. So I cannot make a unicompartmental osteoarthritis if the varus exceeds 15 degrees, of course. So the unicompartmental osteoarthritis is not a corrective surgery for the varus present. So if the varus is high, I should go directly to high tibial osteotomy or total knee replacement. What's your opinion, sirs?
I agree with you, Professor Mohamed. To start with, a young age group was one compartment affected. When the patient is not a good candidate for total knee, we prefer to do joint preserving surgery for varus malaligned in a healthy lateral compartment. In a young patient, highly active patient, we should treat the malalignment at first by doing varus osteotomy. The unicompartmental could be used in advanced osteoarthritis of the medial compartment, but with no malalignment, as you said. So I agree with you, but if you make rules for treating osteoarthritis by surgery, we start by which group we need. We need joint preserving or total knee. Joint preserving could be done for young patient, active patient, mild, moderate osteoarthritis, and one compartment osteoarthritis. So one compartment could be treated by with varus malalignment or valgus malalignment, could be treated by realignment osteotomy. Now it's a new research of doing fibular osteotomy and medial compartment osteoarthritis with no varus malalignment. So we must differentiate between which is better to do. It's which group. If you are dealing with non-arthroplastic surgery, we prefer to correct the mechanical problem at first, either malalignment problem or mechanical problems inside the knees due to meniscal or cartilage injuries.
Yes, sir. Dr. Srinivas?
My distinct take on this is I look at the age of the patient first. If the patient is about, say, 40 years, less than 50 years, I think an osteotomy is probably a better option. For higher age group patients, maybe later 50s and 60s, with affecting unicompartmental, then a unicompartmental knee arthroplasty is a better option in those patients. Again, obese patients, those who don't do well with osteotomies, you could offer a unicompartmental knee arthroplasty. So the main factor is age of the patient, and we should also look at how the results of a knee replacement will be after each of these procedures. So again, associated factors as well will come into the picture when doing the procedures. So the results after a high tibial osteotomy and after a uni knee replacement are comparable. Actually, if you take a knee replacement done after any of these procedures, both are similar. So I think the age is the main criteria in my view.
Yes, sir. We have a question from one of our attendees, sir, one of our colleagues, regarding the fibular osteotomy. Would you prefer it over the two other options of high tibial osteotomy and unicompartmental arthroplasty?
Fibular osteotomy indicated when there is medial compartment osteoarthritis with no malalignment. If there is malalignment, the malalignment should be treated at first. Fibular osteotomy is indicated in patients with medial compartment osteoarthritis, healthy lateral compartment, good range of motion, younger age group. Till now, there is little publications published on it, but the results are encouraging. As regards biomechanically, it will decrease the load in the medial compartment, so it will improve the biomechanics of the medial compartment. It's simple operation, easy operations. There is no implications of it. So it could be used only in medial compartment osteoarthritis with normal alignment in young age, healthy lateral compartment with good range of motion.
Yes, sir. I have a question, sir, for you, sir, and you and Dr. Srinivas, regarding the post-traumatic arthritis. Is there a rule for osteotomy in post-traumatic arthritis?
It depends on what happened after trauma. If this is malunited plateau fractures, this is malunion, and this is cartilage damage. So it's with malalignment. It's much better to start by doing unloading osteotomy. The osteotomy is around the knee, or what's called knee osteotomy. The another term is unloading osteotomy. Unloading osteotomy, it will unload the compression on the injured part. You can start by it. If you are confronted with a case of tibial plateau fracture malunited with degenerative articular cartilage, you can do unloading osteotomy, either medial or lateral, according to the compartment affected. It will delay the need for osteoarthritis, for total knee replacement.
Yes, sir. I'm asking leading questions, sir, so we can get the maximum benefit from your previous experiences and your long experiences, sir. We have no other questions. Dr. Srinivas, you have any comment before we close our session, sir?
I think regarding proximal fibular osteotomies, I think the evidence is not clear-cut with proximal fibular osteotomy yet. We don't have much of high-quality studies in the literature. We have a lot of publications from China on this subject. I think we should see more evidence on this. So I have not personally incorporated this into the routine management of my cases. So that is my view on proximal fibular osteotomy, actually.
Thank you so much, sir. Now we come to the end of our webinar tonight. Finally, I would like to thank my dear friend, Dr. Srinivas, for his participation throughout all the webinars in this course. Many, many thanks to my dear professor and my mentor, Professor Osama Hegazy, sharing his very long experience with us. Many thanks to OrthoTV and to Eva our pharma company for sponsoring this webinar. And see you next Friday, inshallah, with 2 more eminent speakers. Thank you so much, and see you. Have a nice time. Thank you so much.
Thank you, sir. Thank you very much.
Thank you, sir.
Bye-bye. Good night.
Thank you.